What is the role of ultrasound in surveillance of head and neck cancer? I'm Francis Deng, a neuroradiologist at Johns Hopkins and podcast editor for the American Journal of Neuroradiology. In this episode, I'll be summarizing a recent study published in the AJNR entitled Diagnostic Performance of Ultrasound in Neck Node NIRADS Category 2. The first author is Richard Dagher, and the senior author is Kim Learned, based at the University of Texas MD Anderson Cancer Center in Houston. First, some background. NI-RADS, or the Neck Imaging Reporting and Data System, is a standardized system used to assess imaging findings during surveillance of patients with treated head and neck cancer. That is, these patients have undergone definitive therapy and are asymptomatic, and so one is evaluating for disease recurrence. The goal of NI-RADS is to improve communication between radiologists and referring clinicians, as well as provide structured management recommendations based on imaging results. I routinely use NI-RADS in my practice and find it's really helpful in ensuring that my reports are clear and actionable rather than vague and non-committal. At its core, NI-RADS is a system to express the degree of uncertainty that a radiologist has that a certain patient has active tumor. There's a score from a scale from 1 to 4 that is separately assigned for the primary tumor site in the air digestive tract and in the neck, meaning in the lymph nodes. So NI-RADS 1 means no evidence of recurrence, NI-RADS 2 means low suspicion for recurrence, NI-RADS 3 is high suspicion for recurrence, and NI-RADS 4 is definitive recurrence. Each of these categories is assigned based on imaging features which vary by modality employed for surveillance. Specifically, there are separate tables describing the imaging features on contrast-enhanced CT and PET, as well as for MRI. Each category comes with its own management recommendations, and the features and management recommendations differ for the primary site and for the neck. And so for the purpose of this summary, I'm going to focus on the neck because that's the topic of the article. NI-RADS 1 for the neck on CT consists of expected post-treatment changes, non-mass-like distortion of soft tissues, and no enhancement to any residual nodal tissue that was abnormal on the pre-treatment imaging. The management recommendation is to obtain routine surveillance. NI-RADS 2 of the neck on CT consists of persistent areas of heterogeneous enhancement in residual nodal tissue, that is, tissue that was abnormal on the baseline imaging and persisted to be abnormal on the follow-up surveillance imaging with heterogeneous enhancement. Alternatively, you could have enlarging or newly abnormal lymph nodes without necrosis or gross extranodal extension as defined by invasion of adjacent structures. These findings are probably benign but merit a deviation from the routine surveillance, and the management recommendation for these is to obtain a PET if not already obtained as part of this surveillance time point, or to obtain short interval follow-ups such as at 3 months. NI-RADS 3 for the neck on CT consists of enlarging or new lymph node with abnormality, including necrosis or gross extranodal extension defined by invasion of adjacent structures. The management recommendation for NI-RADS 3 is biopsy if clinically indicated. And then finally, NI-RADS 4 definitive recurrence indicates pathologically proven or definite radiologic and clinical progression, and this does not require any further workup and can go on to appropriate clinical management directed towards the tumor. I'm going to focus on neck NI-RADS 2, and this means that a node is mildly suspicious. The literature shows that about 14 to 15% of nodal NI-RADS 2 cases are ultimately found to be tumor recurrences. And again, the standard options for management for neck NI-RADS 2 includes getting a PET CT if not already performed and a repeat contrast CT in about 3 months. However, these options can lead to ongoing uncertainty, increased healthcare costs because of high price imaging, as well as patient anxiety due to equivocal findings that often persist on the follow-up time point. So, we bring this study by Dagher and colleagues that investigated whether diagnostic neck ultrasound with or without ultrasound-guided fine needle aspiration might be a cost-effective and accurate alternative for evaluating nodal NI-RADS 2 cases. At the author's Cancer Center, they routinely add neck ultrasound with optional FNA for such cases to clarify ambiguous findings and guide further management. The authors conducted a retrospective review at their institution, looking for patients with treated primary head and neck cancer who had a single neck node categorized as Neck NIRADS 2 on surveillance CT for primary head and neck cancers, excluding thyroid and melanoma. A diagnostic neck ultrasound with or without ultrasound-guided FNA was performed within 3 months in these patients. Let's take a moment to review. For the viewers that can see the video version of this podcast on YouTube, Spotify, or Apple Podcasts, you can follow along, but this is in figure 2 of the paper. Normal lymph nodes have a homogeneous hypoechoic cortex, an echogenic hilum, and an overall reniform shape that may be better seen on the longitudinal axis as here. In contrast, abnormal lymph nodes on ultrasound were defined by features such as a round shape. Lacking the hilum, you could have an eccentric bulbous cortical enlargement, again lacking the hilum, disordered vascularity, or internal heterogeneity, which is often due to cystic or coagulative necrosis. Here are the results. Overall, the rate of ultrasound-detected and FNA-proven malignancy in Neck NIRADS 2 nodes was 20%. There were a few false negatives, either with negative ultrasound or negative or indeterminate FNA, that then developed a recurrence in that node within a year. But overall, the sensitivity of ultrasound in FNA was 82%, and the specificity was 100%, and the accuracy was 96%. Figure 3 shows an example of a new lymph node next to the flap for oral tongue reconstruction, which was categorized as NIRADS 2, and this ultrasound showed a normal lymph node with a hypoechoic cortex and echogenic hilum, suggesting benignity, and this was stable on a 2-year follow-up, indicating this was a true negative ultrasound evaluation of this Neck NIRADS 2 lesion. Figure 4 showed a round 1.2 centimeter right level 2 lymph node that was enlarged from a prior comparison study, and here's the correlate on ultrasound. This was a rounded lymph node without a fatty hilum, so abnormal. FNA was performed that showed metastatic squamous cell carcinoma, and PET-CT shortly afterwards showed intense uptake in that node, as well as distant sites of uptake in the hilum of the chest, as well as bony sites in the axial and appendicular skeleton. One of these was biopsied and confirmed bony metastasis. And so therefore, this was a true positive ultrasound that confirmed disease recurrence, and the patient underwent further chemoimmunotherapy. The authors propose that incorporating neck ultrasound with targeted FNA in the evaluation of Neck NIRADS 2 findings provides additional clarity. Figure 5 is the MD Anderson guidelines for a modified NIRADS system that includes these. So if you have a residual new or enlarging node without necrosis and without gross extranodal extension on contrast-enhanced CT, with or without PET, and if you perform PET, if you didn't have intense FDG uptake, then it would be characterized as NIRADS 2, and the management recommendation, according to the modified MD Anderson NIRADS, would be to obtain an ultrasound, but other options would include short interval follow-up as well as PET if not already obtained. And the decision to obtain FNA would then be guided by the findings on the ultrasound. The idea is that ultrasound can downgrade truly benign nodes, sparing patients additional high-cost imaging and the anxiety of waiting. At the same time, it can rapidly escalate care for patients who have truly malignant nodes by expediting that confirmation and letting these patients get on to retreatment. The limitations of this study are that diagnostic ultrasound and FNA are highly operator dependent, and the results may not generalize to all practice settings, particularly where experienced sonographers or resources for immediate FNA are lacking. The bottom line is that this study bolsters the case for integrating neck ultrasound with targeted FNA into the management pathway for equivocal, i.e. low suspicion nodal NIRADS 2 findings. It's a valuable addition to the surveillance toolkit, offering high accuracy, excellent negative predictive value, and streamlined management for both clinicians and patients. Thank you for listening to this episode of the AJNR podcast. You can find the full article and figures online at the AJNR website. I'm Francis Deng, and I hope you found this summary helpful for your practice and teaching. Until next time.